Right, this is an important session. Thank you for coming. We've arranged it relatively short notice before the NHS England decided to delay the launch of Care.data, but that gives us more time to reflect on the issues and to hear the evidence and the issues raised by the evidence. What I'd ask each of the witnesses to do to begin with, please, is simply to introduce themselves and explain in a very few words the body they come from and the point, not the point of view, simply the body you come from. Otherwise we'll be here forever.
My name is Nick Pickles. I'm the director of Big Brother Watch. We're a privacy and civil liberties campaign group.
My name's Phil Booth. I'm the coordinator of Med Confidential. We're a non-partisan independent group campaigning for confidentiality and a consent in health and social care.
I'm Chand Nagpal. I'm chairman of the British Medical Association's GPs Committee. We represent all GPs across the UK, 46,000 in total.
Hello, I'm Shamila Nebrajani. I'm the Chief Executive of the Association of Medical Research Charities, which represents 120 odd medical research charities who are interested in funding and executing medical research.
I'm Peter Weisberg. I'm the Medical Director of the British Heart Foundation, and we're the major funder of research into heart and circulatory problems in the UK, hence our interest in this.
Thank you. I'd like to begin really with a very straightforward question and ask each of you in turn to summarise for the committee what you see as being the main motivation behind the Care.data programme. Why do people think it's a good thing and why is it important to those people? And then to summarise to the committee the areas which you think should raise concerns and how those might most directly be addressed. In other words, to summarise the arguments for and against so that they're clearly on the record at the beginning of the session. Could I start with Nick Pickles?
Thank you. I think none of us doubt that there are very laudable aims behind medical research about improving transparency of outcomes across medical treatment and also making sure that we detect problems in the health service. They're all very, very laudable aims. What I think we've got to a point is that Care.data has been given as the only option to achieving all of these aims at the same time. And actually I think there's a number of different avenues that could be pursued that would deliver the same benefits, but would actually engineer into the system a far stronger protection for patient privacy, a far stronger mechanism for consent to be obtained, and also more transparency, which I think is very important to maintain trust going forward. I do think it's important to note that this is the first time we're having this debate, but it's not the first time that patient data is being used nationally from various sources. And I think one of the things that should go on the record very urgently is that any future plan to use patient data in an identifiable or even pseudonymised format should always come with a full, transparent conversation with the public and a consent mechanism. And I think it's very positive that this Secretary of State has recognised that, and I think that should be the norm going forward, and we should not return to a system where things happened and patients didn't know about them, and that was taken as consent. Having said that, clearly the communications around Care.data have been far from adequate. I think NHS England needs to take responsibility for that. We've been working on this issue I was checking my emails, nearly exactly a year now. And one of the first things we raised was the summary care record. Every patient was sent a letter and an opt-out form, and that should be the bare minimum of communication. And I don't know who decided that a leaflet was adequate for a scheme of such magnitude involving such sensitive information, but that decision was plainly wrong, and a leaflet was not adequate. And so I think that needs to be on the record as well. Broadly, our concerns, the failure for the public to be properly informed about what was happening, the use of data, the broad transparency of this whole project. The conflation of different uses that I touched on, I think, could have been much better explained, and if we'd been having this conversation a year ago, some of those uses might have been separated out. So you wouldn't have the same conversation about commissioning as you would with research, because patients have different attitudes towards that information. I think the particular point about opt-out and the clarity of what information would be extracted where patients did opt out has been something that's been an ongoing issue for us, and we received today actually a letter from the Secretary of State clarifying that we're very happy with. But broadly this...
Just on that narrow point, you're happy with the concept of opt-out rather than advocating an opt-in system?
We are happy with... Sorry, can I just jump in? We are happy with what is being offered at the moment is an opt-out. The problem is that opt-out was not functioning in the way that any reasonable person would understand. If someone had opted out, it was the case that information would still have left their GP record. So until that was fixed, last week, at the same time as the delay, it seems, that was a really serious concern for us and for many patients, of course, and it was basically misleading the public.
And is that in the public domain, or was it just used to share it with a few people and not everyone?
We have received a letter today from the Secretary of State that links to a page on the HSCIC website which now explains what they will currently be doing when someone has put an objection code onto, or when they've got their GP to put an objection code onto their record. Yeah, so it is now public.
And that interfaces with an older document from December, which is the direction, which we're assuming will now be updated by NHS England to reflect that no data will leave your record if you opt out.
Okay. That was just on the narrow... Go on.
Yeah.
Well, it's just saying at this point that was not shared with Parliament as well. No. Although we have and there were 3 questions directly to the Secretary of State on this, and he didn't tell the House, which is disgraceful. Anyway.
And so I think this has been discussed in many different forums, and actually one of the reasons why the delay is a good thing is there's lots of issues that we can flush out now. If for no other reason than to the opt-in point, ask the question in future going forward, actually opt-in is ethically a much stronger model, and informed consent is best tested by opt-in. So I think that's a fair point. And
but that's not what you are advocating. You're accepting the current proposal as refined in this correspondence.
If we have an opportunity, I think we'll probably say the same thing. If we have an opportunity to change it, then I think opt-in does add a much stronger test for patients. But the scale of the pause, I think we're focused more on getting the system working properly than trying to radically re-engineer something.
Well, no.
We'd like to start with that, but we are where we are.
Med Confidential's position is that this should be re-engineered from the ground up. But realistically, NHS England has pushed forward now, despite 2 6-month delays, and it doesn't seem to be relenting from that. So, that being the case, because our primary concern is the patient, and patients' feelings about what is done with their medical records, we take the pragmatic view that we must try to make the mechanisms that are available work properly, that people understand how they can use them for themselves and their families. And yes, we would very much like to say, look, this is a halt, this is the wrong way to go about designing this sort of thing. What you're talking about here is, at its heart, creating an aggregation of the entire country's medical records or extracts of the medical records at individual patient level.
Can I just be clear?
Yep.
What is the connection between the two organisations? It seems that you're talking in unison. I just wondered what your membership is.
So, Med Confidential was founded by a number of organisations, including Big Brother Watch, No to ID, the Foundation for Information Policy Research, and Privacy International. We've been supported by others like Liberty. Med Confidential is basically myself, Terry Doughty, who used to run Action on Rights for Children, and a former member of Privacy International, Sam Smith. Yeah? And then we have like a network of volunteers. We're a very, very small organisation, but in terms of our policy, if you like, I speak to that. Big Brother Watch has its own policy, but as a founder, we work together.
A useful opportunity for my final point, actually, is that something we've been campaigning on for many years now, and it's supported by the Justice Select Committee, the Home Affairs Select Committee, the Joint Committee on the Communications Data Bill, is the broader framework of infringement penalties for breaching the Data Protection Act. And Section 55 in particular, where custodial sentences are not available for those who acquire personal information illegally, is something that I think in this context is particularly acute. And the power is already on the statute book. It's just waiting to be commenced. So from our point of view, the broader issue about information governance and privacy and data protection feeds into this issue as well as a range of other ones.
Could I move on to Dr. Nagpur, please?
Yeah. It's interesting you asked about the benefits, but actually the benefits are lost in actually what is the fundamental problem at the moment, which is around public and professional confidence or lack of in the programme. So just a reflection. But I just want to just describe that the perspective of GPs. We do think we have a unique position because we are, after all, the custodians of the patient data that is to be extracted. So we are in a unique position. And of course reflecting that patients visit their GP, they visit us, and they entrust us with very personal, sensitive, confidential information as part of a lifelong record in general practice. Now, at the heart of our concern as GPs is that if patients mistrust or are concerned about the security of their data or have concerns about how this data will be used, that would actually potentially irrevocably damage that fabric of trust when a patient walks into a GP surgery. And that may actually have other consequences around confidence in the way the NHS records data. It may actually result in patients not attending their GP surgery at all for fear of what may happen to their records or data, or if they do attend, actually be inhibited in being totally open about some things and maybe not about others. And if you actually just reflect, we were just recently talking about patients actually not attending their GP quick enough with suspected cancer, for example. It would be extremely damaging if at the heart of this, patients actually lost confidence and trust about the data that is recorded by their GP. We all plaster it on our websites. If you're registered at our practice, we can assure you of confidentiality. And I think at the heart of this has to be an assurance to the public and patients in particular about the safety of their records that we record.
Could I move on, please, to Ms.
Shamila Nebrajani, yes, too many names. I want to give you a research funder's perspective on the research elements of Care.data, and there are care elements, and you may want to reflect on those separately. It's a research funder's belief that this is a really excellent database, and it is a really valuable asset, but it is being stymied by its execution. And that's partly about the way it's communicated, and we may talk a little bit more about the leaflet and the way in which the public has been allowed to understand it. But also there are some very big unknowns still in the execution of the database. Who can use the data, for what purpose, on what basis, and how opt-ins and opt-outs will work. So there are some real shortcomings here. Let me just start with the benefits, because that's the point that you raised first of all. There is already quite a lot of data available for research. What this system would allow you to do is to link primary care data with secondary care data, and that doesn't happen yet very well, and it doesn't happen at scale. So there is a germ of a really good system here. And the sorts of things that are talked about of its benefits, which the committee will be aware of, things like the link between smoking and lung cancer would have been elucidated in data sets like this. The link between MMR and autism debunked using data sets like this, but also more recent examples. In the flu epidemic of 2 or 3 years ago, 2010, researchers were able to link the sort of primary care data that Dr. Nagpal is talking about vaccinations, with the critical care bed usage in hospitals to identify what was causing the influenza epidemic to be so strong, and to make that link back to a shift from children to adults, and therefore to create a new vaccination programme based on that insight. So there is real value here. Research funders' anxiety is it's being executed rather poorly. And I think there are several issues in that. The first is research data depends on the public having confidence and trust in the system. The public are very generous with both their money and their resource to charities and to research, and we risk eroding that support if the public can't have confidence in how their data will be used. Do you want to come in?
I was just going to ask, but why do you need all the information and everything that everyone knows
about
a patient?
Let's leave aside research and care, because I think research doesn't need all the information, but there is real benefit in having a spread. As you start to have stratified medicines and you start to target groups by ethnic grouping, by genetic makeup, you do start to need groups that are bigger than typical research sizes. At the moment, the research data that comes through GP practices is about less than 10% of all GP practices are feeding into GPRD, which is the precursor of this database. So there will be merit in getting scale. But I don't want to undermine the kind of critical thought, which is there are some execution problems here. The public is rightly worried that they don't understand who can use their data and who can't. There is a real conflation of purpose and identity. So people are very worried about pharmaceutical companies having access to this data. Well, we won't have a drug developed in this country without having pharmaceutical companies involved in the creation of those research projects. So it may be perfectly legitimate for the public to understand how industry can use that data. That's not the same as saying insurance companies should have access to that data. So clarity about who can and who won't have access to data is very important. I just want to come back on the point of opt-in, opt-out and consent. I think a research funder's perspective is this data needs to be used with care because it is the public's most sensitive data and it needs to be used with competence, so the safeguards need to be there. But the patient needs to make an informed decision about whether or not they want their data to be available in the system. Research funders would say that that information needs to be given properly to the public and they need to have time to reflect. So in that sense, this pause is welcome. But an opt-out is sufficiently strong if the information system is good, and that's for two reasons. Number one, the public already tell us they want their data to be available for research. 80% of people polled in a recent Maury poll said they would like researchers to have access to their data. And a second example, in 1.3 million people approached for an ovarian cancer trial, only 32 people complained. So the vast majority of people are happy for their data to be made available, but they do want to understand the parameters around that. The problem with an opt-in is that there is now quite a lot of evidence that you bias your sample away from the very people whose data we want. That's the vulnerable, that's people whose English is not their first language, that's lower social economic groups and it's ethnic minorities. So those are the people who are least likely to opt in, but whose data may be most useful for them for care and for research. So I think we need to think really careful about not conflating consent and opt-out.
Before I bring in other members of the committee, could I ask Professor Weisberg to...
Yes, and I'd say I echo everything that Shamila has said. And just to amplify that last point, this is not an issue about being able to grab data from vulnerable people who don't understand things. The issue about the disadvantage and the ethnic minorities is that is where the burden of disease, particularly in my field, cardiovascular disease, and it's still the biggest killer in our community, that's where the burden of disease lies, and that's why we need that information. So I think I would answer this without trying to repeat what's been said earlier on in a number of ways. So from a health service perspective, it is inconceivable that we can have a publicly funded organisation spending 95 billion or whatever it happens to be of public money on patient care without being able to performance manage that. And you have to have data to do that. So it's an issue we have to crack, and we have to sort out how we're going to crack it, because it's absolute necessity from that point of view. Because of our health service, we have a unique opportunity here because of our nationalised, unified patient database, which could be available for research, something which every other nation in the world would give its eye teeth for if they could only get their hands on it. We have it, we have to learn how to use it responsibly for the benefit of our patients. In terms of explaining what I think the benefits are of this, I'm going to turn that on its head and say what I know to have already been the harms of not having it up until now. I've been around for long enough to have seen a number of disasters, medical disasters, that have occurred not through mismanagement, but through ignorance. I'm afraid there's much more we don't know about medicine than we do know, even in this day. I'm sorry about the Rumsfeldian type of approach to it. So let's start with aspirin. Aspirin, common drug given to everybody, but actually was almost certainly causing permanent disability and death in children when given for febrile illness. It took years for that penny to drop, to make the link between aspirin and Ray's syndrome. When the link was made and the drug was withdrawn, or at least the controls were put on so it doesn't have to, Ray's syndrome has all but gone away. It hasn't gone away completely, but all but gone away. So there's a situation where, for the want of being able to link data, very simply, aspirin and a rare syndrome, it would be very easy to have done a case-controlled study on those data, anonymised, very, very quickly to come up with that answer without having to see people die. Beta blockers, commonly used drugs. One of the first ones that was on the market was called Practilol. I used to prescribe it commonly. Actually, in a rare instance, it caused a very nasty, often fatal fibrotic disease, idiosyncratic to that particular drug. Took us years to tumble to that because the clinical trials didn't pick it up. It was too rare to be picked up a clinical trial. Coming closer to home, Vioxx. I suspect people in this room might have been prescribed Vioxx for a very commonly used anti-arthritis drug. Very good at treating arthritis and actually reduced some of the risks of arthritis treatments, reduced the risk of bleeding, but unbeknown to us was killing people from heart attacks. Again, it took years and thousands of deaths before that penny dropped. We're sitting on that data. It's there now. We could have, had we been able to mine the data in the way that's proposed, we could have got those answers very, very much earlier, saved lots and lots of lives. And the obvious one about lung cancer has already been made. So I think there are numerous examples historically of where not having access to patient data has caused thousands of deaths. And one might argue that you only need, if you want numbers put on it, let's say there is a drug which causes 1 in 1,000 people who take it to die. Now you won't pick that up in a clinical trial because you need to run a clinical trial of thousands of patients, hundreds of thousands maybe, to pick that up as a statistically significant impact. On the other hand, let's say that drug's being prescribed to 10% of our population, and you can think of drugs that are now. I'm not wanting to point finger at any particular class of drug, but there are drugs out there that people are talking to prescribe about prescriptions to about 10% of the population. That means 10% of our 60 million population. If you do the maths, that's 6,000 deaths that's going to occur as a consequence of that prescription. The only way we will pick that up is by access to huge-scale patient data, not just a few thousand, but the millions of patients that are our NHS database. So it is crucially important we're able to make those links. And I would suggest that in any other position where we were causing 6,000 deaths, there'd be outrage if we didn't know about it and if we weren't monitoring data. If it was a series of air crashes or road crashes, it would be on the front pages of all our papers all the time. But because it's unseen to all of us, yet it's in our data, it's unseen to all of us, we do nothing about it. So finally, I mean, to wrap this up, we spend a huge amount of money on research. We've had a big impact on cardiovascular health. A lot of our research is slowing down now because of the difficulties of getting to patient data. It's becoming harder. When we can do it, it always pays off. But it's getting harder and harder, and that was before the recent problems. So we are wholly behind the concept. We are worried about the execution because it's frightening people off, and I think they don't understand the sort of arguments I've articulated today against the arguments we've heard earlier articulated, and there has to be a way of striking that balance and getting it right.
Right, and we need to move on. David?
Yes. Fine. I mean, we've touched on what I'm going to ask you about, but I'd like to formally put the question. The start date for data collection has been put back by 6 months. What do you want to see happen in this newly extended period before the database becomes operational? So perhaps going from through your chair, Mr.
Transparency is the first point. I think that the point around what's the process for getting access to data, who has had access to data previously, audits of security and data use. So for example, the insurance issue that we learned about yesterday, how did that happen? And then going forward, it's worth noting the Caldecott review was obviously April last year, and we're due to have a HSCIC Code of Practice for Confidentiality, which I understand still doesn't have a publication date. So there's some quite important elements of the confidence structure that aren't in place yet. And then we can talk about actually telling patients with a letter, sending an opt-out form to make sure they know what's going on.
So you would very much welcome this pause?
Yes. I would pick up very, very specifically on something that Nick said in terms of transparency and oversight. What has become very clear in recent weeks is that the processes at HSCIC are just simply not fit for purpose for the sort of scale and sensitivity. So very specifically, when a customer, a potential customer, comes to HSCIC to ask for individual level patient data in various forms, they will ask for this, request this, and then possibly be bumped off in to different bodies. One of those is the Data Access Advisory Group, which sits on requests for what is internally termed sensitive data. And another possible avenue is going straight to the asset owner, the people who are in charge of that particular data set, if it's not considered sensitive. Given that we only get sight of those decisions that are made by this Data Access Advisory Group, which is, by the way, we believe just 4 people, 2 of whom are HSCIC, 1 of whom is the Department of Health, and 1 other, given that we're finding out that there were unminuted, out-of-committee decisions being made about access to data by, in one instance, I think it was Cabinet Office, and we're seeing now other instances where data has clearly gone out from HSCIC, and there is just no record of what it is. So we would want, in this 6-month period, as Nick says, we would want a complete, comprehensive, historical record of what actually has gone out. Where has our data gone in the past? If we're going to move forward, then be very, very clear about the process by which people then, companies, organisations, what have you, bodies, can then apply. And we would recommend a body much more along the model of something like the Confidentiality Advisory Group, which has now moved to the Health Research Authority, which is a fully independent body, which presides and looks at applications for what's called Regulation 5 or Section 251 support, which is when the duty of confidence is set aside so that identifiable patient data can be used without consent. Let's treat all of our country's data, every man, woman and child's in England's data is going to be in this database if it proceeds. Let's treat that with the sort of sensitivity that it should demand. Yeah? Okay, HSCIC say they are putting some of this out in pseudonymised form, but I'm afraid this is not anonymous statistics. There remains a risk of re-identification because of the way it's treated, but it is in the nature of episodic health information about a person that it is re-identifiable, because you can go at it lots of different ways.
Through you, Chair, I know colleagues want to come in on this through the Chair, it's quite obviously, but I would like, through you, Chair, to go down the line, as it were, and hear your answers, all of you, to the question that I've asked before we have the secondary questions, please. So, Dr. Nagel.
I mean, the most important thing we'd like to see is to have public confidence and trust. As a GP, that's what I want. I want my patients to walk through the door feeling confident. And for that, you have to have a fit-for-purpose public information campaign, not a leaflet advertising campaign, which is what we actually got. And that needs to allow patients and the public to have true informed choice of whether they want their data extracted or not, but they need to also understand both the benefits we've heard, the risks have to also be understood, but they also need to know what is extracted, and they need to know about the limits of what that data will be used for. Not something that says it may be used for this today and something else tomorrow. They need to know exactly what those limits are at this moment in time. We also need to have absolute assurance around the governance of that data, assurance around who can access it. We would want to see an independent scrutiny of the use of data from the Health and Social Care HSIC. We believe that there should be independent scrutiny of its use. But I also want to just talk about something very particular to GPs that we want to see happen. Because GPs are in a seemingly impossible position. On the one hand, they have an obligation under the Health and Social Care Act to upload confidential patient data without patient consent. That puts us in a very difficult position. And at the same time, GPs are duty-bound legally as data controllers under the Data Protection Act. Therefore, if we upload that data under the Act, but if our patients are not aware that that data is being uploaded, we could actually face a legal challenge and a complaint. Now, this is an important issue that actually is affecting GPs, and we would want to see some indemnity that if GPs do what they ought to do, and they've done it, should they face a legal challenge, it would be completely wrong if they then unfairly had to face legal consequences for doing everything they could because of the Act's requirements.
To the patient or to the...
I think that is a problem, because if we were to not, and there have been doctors who have suggested that they would not upload data unless it was an opt-in, have actually been threatened with breaches of contract and actually breaking the law. So we are in a difficult place.
Okay, so we go to Dr. Mr. Nebber.
Thank you. I'd like to divide my my asks, if you like, into two populations: the things where execution needs to improve, and the things where communication needs to improve. So, firstly, in execution, I really think NHS England is in a bit of a muddle about this, and they need themselves to be clear about how data will be managed and the relationship between HSCIC and Care.data and the existing research relationships before they start to talk to other people about it. And some of the difficulty we have is because they're trying to explain something that they have not themselves decided they're settled will. Well, that's a recipe for disaster. So the first thing is backing themselves to work out what's in and what's out. Being more specific, I think it's really important they are clear what purposes are legitimate ethical uses of research data and what aren't, and they need to say that. The second element of it is they need to set out who are legitimate users of this data and who will not be. In fact, that's related to purpose. So there's been a lot of conversation, for example, that insurance companies should not have access to this data to help them to mitigate or to pursue their own commercial objectives. I would agree. I think the same thing applies to the Department for Worker Pensions, actually. So being clear about what's in and what's out by purpose, I think, is very important. The second thing I think NHS England needs to be clear about is what are the safeguards they themselves are going to put in place to protect privacy and security. And then they need to tell the public about that. Now, the public know, in the same way that they know that no medicine is 100% safe, they know that no data system is 100% safe. So again, the conversation that has to happen with the public is all about risk and benefit, the goods and the harms, and we need to have that in a reflective way that allows the public to come to their own informed decision about whether they want to participate or not. The third thing is on the right to object. As I currently understand it, the right to object is not a legal right. So the public can express an opinion, and by discretion, the Secretary of State will adhere to that opinion. That may be fine. I mean, you as the committee will be able to judge that. That may be fine. But I think we should tell the public that that is the case. So I think that's the third bit of wiring that needs to be sorted out. I think the fourth thing that needs to happen is to be really clear, what does opting out mean to the public? So does that mean, for example, if my data has gone into the system and then it's gone out to Dr. Nagpal to do research, and I then withdraw my consent, does he have to give my data back? Can he keep it? Unclear. So we need that degree of clarity before the public can have confidence in the system. If I opt out before he gets the data, can the HSCIC say we're going to delete it and it'll never go out again? Again, we just need to be clear. I think the public understand the precepts of research, they're supportive of it, and they'll make their informed view, but it has to be informed in what is and isn't going to happen.
Right, and through you, Chair, lastly, Professor Weisberg.
Yes, I'll try and be brief because I agree with everything that Shamila said there. I think the whole issue here is that the issue of being able to use patient data for management of the health service and for research is too important to get wrong. And I think that's why we welcome the 6-month pause, because it was going wrong. It was going wrong for a variety of reasons, some appropriate, some inappropriate, and we do need to take stock. You ask what do we want to see happen in that time. Well, I'd like to see much better information for patients that articulates the benefits which are clearly able to be articulated. We can give numeric examples. I've given you some of where the benefits accrue. I think we should also articulate what the risks are, but there needs to be proportionality there. We all know there is a risk to any of our data that can be acquired, whether it be from the DVLA or any other number of databases that hold our data. But the issue really is, what is the likely risk that somebody is going to hack into a system to identify your personal data in this situation and use it against you? And it's a real risk, but the issue compared with the benefits of the whole is a relatively low risk, I would suggest. But that's got to be argued and that's got to be articulated. And I think there does have to be absolute clarity as to how the data flows and who has access to it and who doesn't. And in answer to the question that was put to my GP colleague and goes, what is the priority? Your responsibility towards your patient or your responsibility towards collecting the data? I would say they're equivalent. I mean, I'm a doctor who sees patients as well in hospitals. I have a priority to look after that particular patient, but I also have an obligation to try to use the information I glean from doing so for the greater good of other patients that come on afterwards. And all of us who go and see a doctor are benefiting from the research that's been done on patients before us. Admittedly, nearly all of it done through a rather laborious and heavy-handed consent process, which has limited our ability to get that information. I think the public is very aware of the fact that we need their data to make patient care better in the future. They just need to be given the facts in a clear way so that they can make a sensible judgment.
I don't think there is a member of the committee who hasn't been seeking to catch my eye. So I'm going to go to Barbara, and then I'm going to go to Charlotte, and then back to Graham.
It's a second part to this second question, actually, and I think it's more or less directed at Med Confidential and Big Brother Watch. It's about, if you could tell us more about your view of ways to handle the patient data safely. And the thing I'm interested in, I think you haven't mentioned it in detail yet, is the idea of only having one primary copy of the database, so that those wanting access, if they have a plausible use that is allowed, could then submit their query or queries to people who would run that for them. Now that seems to me to get over the problem that Shamila's just said about somebody withdrawing their consent after a copy of the data has gone out to somebody. You seem to have illustrated perfectly well the reason why there should only be one copy, the people responsible for it should keep that copy, and the customers, if we have to call them that, for this, should submit queries which are then run by the independent experts. So,
yeah,
I mean, that seems to me to have a lot to recommend it. Could you tell us more?
Okay, this was simply a suggestion that we have made based on what is becoming good practice in some areas of handling what are called big data sets. Certainly ones that I think have been handled with regard to some government gathering of that data. Essentially, the idea is that this is so sensitive that you can't be handing out chunks of or copies of the data set to allow another third party to then do processing on it themselves. That's inherently risky. Once you've got lots of copies out there, quite evidently there are more vectors for attack, there are more possibilities of breach and so forth. So the idea is of keeping this completely contained in one place where you can put the top levels of security. I mean, really, high levels of security in, and then, as you say, having a process whereby there's independent expert scrutiny, not just of, oh, we want to use it for something, but actually, a direct request or query that is going to be done on this database, so that can be looked at, people can have a guess, an informed guess at what's likely to come out, but then that data can be checked on its way out and treated in many of the ways which people are very used to now, pseudonymization being one of those ways, so that the query coming in is checked first, the access to the database is tightly limited, and any data coming out, and this is just the answer to a query, not a copy of a chunk of the database, can then be checked for its safety, again, independently, before it leaves the facility. That's, tightly locked down, and we're, clearly sort of talking about a sort of the extreme other end of the scale to what is being going on at the moment. But we certainly think that the public would have much greater confidence in a scheme that treated their and their family's data as that sort of precious asset rather than some sort of tradable asset, frankly.
And is that principle already in use in government systems?
Certainly. So the ESRC has commissioned some sort of facilities for academics to use, I believe in university. I can write to the committee about specific installations or what have you afterwards.
I think there's actually a specific point that is important there is when the Data Protection Act was transposed from European law, there is legal opinion that the way the UK transposed that directive left the loophole that did not criminalise re-identification. and that's not consistent across the rest of the European Union. I understand it's a specific problem for the UK and Ireland, but actually to speak to your problem, if you're allowing data out and you have not criminalised deliberate re-identification, then you are magnifying the risk. So if you keep it in one place, you don't then rely on needing to change the Data Protection Act as well to close that loophole for third-party re-identification, which, as Phil says, the more copies exist, the greater that risk becomes.
Could we just have the other side
Yes,
of the house? Is that a workable solution from a researcher's point of view?
It might be. I think it might be. I think the key thing is what is the impact on the patient. So to your point about if the data has gone out, once it's in a researcher's data set, it's in a researcher's data set. So it is hard to disaggregate that from once the consent has been withdrawn. So I think a simpler answer, and I'm no technical expert, but a simpler answer is just to be clear with people when they opt out, what happens, and when, if that opt-out happens some way down the line, or as the leaflet puts it, you can change your mind as often as you like, what the risks are about what data can be removed and what data will not be removed. Because I think it is not something that there's necessarily a technical solution for. There has to just recognise that once data has gone into a project, it's gone into a project.
Can we then go to Charlotte?
Sorry, just very quickly, Shimona reminded me of what I was trying to... So the opt-out process at the moment does not delete data, even that's held at the HSCIC. This sort of approach would allow someone to provide, say, their NHS number, identify all the data that had been taken up, and to delete it at source. So you're absolutely correct. That is one major guarantee that could be given to patients to provide them with some confidence, because at the moment it just isn't there. At best we have heard under request for freedom of information request that data may be anonymised prospectively if you say you want to opt out after it's been uploaded.
Yeah, Rosie, can we go...
Can we just ask bearing in mind what we talked about before, just what does opt-out mean? What does it really mean? Because there's actually no such thing as opt-out, is there?
Well, it's what we now understand from what the Secretary of State has written to us today, and what the Director of Clinical and Public Assurance at HSCIC wrote to us last Tuesday, is that if a patient does what's called a Type 1 opt-out, they have a code added to their GP record, and as of today, we have the assurance of the Secretary of State that no data will be taken from their GP record. What will happen is that the total number of those objection codes will be counted up for each GP practice, and just that aggregate number will be sent to the HSCIC. The other code, which the GPs are being asked to administer but isn't actually anything to do with them, is that if you want to opt out of having your identifiable data passed on by the Health and Social Care Information Centre, because of course it gathers data from all sorts of places that aren't your GP record, you send what's called another objection code up to the HSCIC, and that must carry with it, and it only, this piece of information, which is the NHS number. Using the NHS number, then the HSCIC is able to identify your information as it comes in, and then that's the way in which it's going to be able to stop it going out. Without some sort of way of identifying the data that goes in, just logically, it would be impossible for HSCIC to identify your data coming from a clinic or a pathology lab or a hospital or what have you. But to be very, very clear, no other data. This is a separate extraction. If you are opting out of having the HSCIC pass on your data, the way it should now work is that they literally only take up the fact of your objection and the NHS number, which is used only for the purpose of identifying incoming data.
Just one very quick question. So those people have opted out already?
Yep.
Which bit will they be in or out of?
So that will be, if they've had both, one, other or both of the codes added, that's how they will operate.
The member of the public doesn't know one or two, or code or not. They say, I want to opt out.
Exactly.
Where are they? Because they haven't seen the Secretary of State's statement today, neither have I.
So,
my understanding, up until you've just spoken, was that some information, or the information would go, but not be
this is the problem. It has been, we contend, it has been presented misleadingly to the public. There have been these two codes and that's been miscommunicated, but it has been misleading because the position when we read the privacy impact assessment that was published by NHS England was that they said there in terms on page 9 that if you opted out, clinical data would still flow. That's why we got in contact with the Secretary of State. That's why we've been basically trying to pin this down and why we're glad today that those people who already have opted out using both codes for the full protection, if you like, and one or other for protecting...
No, we can't have a
direct... say I opt out, what does Secretary of State take that to mean?
I think this is the point, actually, this is the issue for GPs. So if you download a form from either of our websites that says we want to opt out, that goes to your GP. There are 2 opt-outs. Now, is that the burden on the GP to ask you which one?
I think what we need to do is use this very sensible pause. I would commend that government use pauses more often in the future, but, you know, I think it's very sensible. And you know, I think that we're asking the wrong question. We now have an opportunity to actually get it right, to actually, for patients to understand what opt-out means and to make it simple for GPs to administer. What I think also I would want to suggest is that from the BMA's perspective, we also last week had a debate and we also wanted to introduce the idea of pseudonymisation at source, which would actually mean that when the data leaves the GP practice, it cannot be identified and it would be replaced with a key. There's a technical way of doing it, but that again would assure my patients that in fact at least their data could not be identified. Now, I'm not a technical person and there are probably pros and cons around this, but it's certainly something to consider. But I would like to say that we should use this opportunity to get, and we don't have an opt-out form at the moment. The opt-out process, actually, there is no form. So at the moment, as we speak, you would not have a form to complete.
No, I've opted out.
Okay,
but hang on, under that system I'd opt in. But I just think we're taking the great British public for granted, and it's an outrage.
Charlotte Leslie.
I think we've just learnt that we don't know what an opt-out means, and that's what we need to do in the 6-month period, haven't we?
One of the things we need to do.
Yes, one of the things. And just, it's a very quick question. Do you think there'd be any merit in kind of a more granular approach to opt-out? Because I think if the data's completely anonymised, many ways people are not so fussed about their data, there might not be such a need for an opt-in option. If it's identifiable, there's definitely a need for a very informed opt-in option if it's identifiable data, and if it's in the middle and pseudonymised, maybe you have the in-out option. Do you think there's a need for a granular opt-in, opt-out, or do you think it's overcomplicating things?
I'm afraid you're looking at the end of the process.
Yes. Okay.
That would make the opt-out even more complicated. The fact is that unless the opt-out is actually, it's been split into 2, but using both of them is probably the best or the safest you're going to be. The data, if you do not opt out, that goes up from your GP practice is identifiable. That's without dispute. Yes. So the opt-out has to basically operate in the way that we now hope it does. We think it should be made simpler because we think it's a nonsense, frankly, to say someone has to choose twice to opt out of something, when clearly if they have concerns or concerns enough that they don't want their GP record to be going up to this central database, that they'd be perfectly happy for any data gathered from anywhere else. That sort of seems to indicate that the opt-out was designed not for patients, but for the institutional demands of NHS England in its Care.data programme, because it wants data to flow.
Could we hear the...
It's just a brief comment, but in this world, terminology is really, really important. So when you're talking about identifiable data and you're talking about data, you are not talking about the same things, I think. So the first thing to say is, I don't think there's any break at the moment on the use of anonymous data. So the opt-out is completely alien from the concept of... We have no rights over our anonymous data in the current world, it just goes up. Identifiable data, genuinely identifiable data that says Shamil Nebrajani, Brighton BN2 1NA, absolutely tightly controlled. And so what we're talking about is this issue in the middle of pseudonymised data, which I think will be better described as could be identifiable or coded. And I think, again, back to my point about this being a bit of a blinking muddle, getting the terminology right across all elements of the NHS when we describe this would help us decide what we wanted, and we are not even clear about that. So I think just to come to sort of the opt-out point, I think there are sort of three things about the opt-out. Number one, it isn't an opt-out; it's the right to object, and it just doesn't have legal force. So I think that, we need to form a view about whether that's the right thing or not the right thing. The second thing is at the opt-out stage that one has to have a sense of where the opt-out can happen. Do I want my data to leave the GP? And then do I want my data to leave the information centre? And those are those two-stage opt-out. I think that's very complicated for the public to understand. So again, if we weren't starting from here, we might design again a different way of cutting that process so that it was clearer. Because you still have the ability to use, as you described, pseudonymised or key-coded data in a sensible way. I think the third thing I'd say is we're in a really awkward conflation of identified, pseudonymised, anonymous, and data security. They are different things. We need to design a system for the use of data that works, and then expect that some people will try and break the system and need safeguards around that. But at the moment, we've got an awkward conflation of securities, hackers, system failure, and system complexity, and we need to solve those two things separately.
Right. Great.
Well, you've come to the real crux of it, identifiable data, and I wonder if you might clarify for mine and the committee's benefit from a research and service provision point of view, for what reasons pseudonymous data is preferable to anonymous data, and then for Nick and Phil, from a privacy point of view, what are your concerns about pseudonymous? I can't even.
It's a dreadful word.
Pseudonymous data.
Pseudonymous.
Can I ask your opinion as well? Can I just, because I've sat very patiently. When you were talking about identifiable data, because you're in the confidence of the Secretary of State, you've obviously got information that I haven't got. I'm just a member of Parliament.
Sorry.
But a Section 251 exemption now allows the use of identifiable data for commissioning purposes.
Yes.
So that there are organisations nationally, NHS England, and you might say that's a good thing in terms of identifying trends and some of the examples that you gave. But nevertheless, this identifiable data is currently being made available at a national level to NHS England, at regional levels to NHS England area teams, at a local level to clinical commissioning groups and local authorities. What's your views in terms of the privacy there? Is that something we should be addressing?
Well, sorry, on that very particular point, it is Dame Fiona Caldicott specifically said she did not accept the proposition that identifiable data was required for commissioning purposes. So we're stunned, frankly, to see that it was given Section 251
for
support.
audit and invoicing purposes as well. I mean, it's not required for the work. It shouldn't be, should it?
Yeah. So this is the case that things have got all out of order. Okay, we haven't got clarity. We haven't even got a system that's clear. Yeah, data was imminently to be uploaded. Thank goodness it's now pushed back at least to the autumn. But despite that, NHS England applied for and was granted Section 251 support, this exemption to pass around identifiable data, back in April of last year. By October, none of that data had actually flowed, bizarrely, given that they said this was critical for their purposes, and we now learn in the minutes of the Confidentiality Advisory Group that this has been extended and will probably be extended again. So what we have here is a pathway which is being kept open for the passing of data that contravenes the recommendation of the Caldicott 2 report, and that for us is absolutely stunning.
Is this an example of mission creep? Potentially?
Absolutely. If you are starting to bring up identifiable data, and by identifiable here I mean stuff that is tagged with your NHS number, your full postcode, your date of birth, your gender and your ethnicity, which is more than enough to identify pretty much any person in the population, that identifiable data will be going up to HSCIC, and if it is the case that they already have, that NHS England already has this Section 251 to support to pass around identifiable data, the public has once again been misled. Because in the documents that are being sent out, in the leaflets being sent out, It's being presented as if your identifiable data will only be used in the case of a public emergency.
I think from the facial expressions, not all your fellow witnesses agree with all those
I don't disagree with what you're saying, but you're talking about a very, very narrow bit of Section 251, identifiable data. I want to come back to the crux of your question, as you put it. We are really in danger of throwing this baby out with this rather grubby bathwater, and I don't work for NHS England. I'm not apologising for what they've done. I think it's really, really clear that we remind ourselves why this linked data is so important, and that is not Section 251, and that is not identifiable data. That is not identifying me, Shameen Ebajani. It is linked data, and it's important for two things. I'll give you two examples. Number one, a long-term study that looked at the prescribing of oral contraceptives in GP practices, looking at data that came from GP practices, was able to link with mortality data and cancer outcome data in hospitals, and you were able to link those two and find out whether there was or wasn't a link, a risk link for the use of oral contraceptives for those patients. You would not be able to do that if there was not some way of matching those data. You didn't need to know it was me taking the pill, but you did need to know that that piece of data there was linked to that piece of data there. And that's a really, really important resource. And it would be a disaster, I think, from a research perspective, if that concept and that asset were lost in this muddle.
I've got, this is not the time to be emphasising the benefits when there is so much wrong with the structures, the privacy, the lack of consent, and the security. Frankly, you know, it is just a waste of time. They're nice examples.
What's a waste of time?
It's a waste of time to spend the time now until we have the security, the privacy, the consent, all of those issues. You've given loads of examples of things that should have been thought about months ago. So it's really just a waste to be talking about benefits, because frankly, I think most patients should be scared to death of the mess that this is.
So let me just reiterate my comments at the beginning of this meeting, which is this is a really great system, stymied in its execution. Yes. I do not mean to minimise the difficulties that have to be solved, but what I am simply saying, and I'm sure the committee would accept this, that in any decision there needs to be a balance of the benefits and the risks.
You can't balance that against the loss that there would be, the loss of privacy.
I'll leave it with you.
You can't.
We've allocated an hour to this. Professor Weisberg hasn't had a say.
Can I just say, and I'm not going to counter anything that's been said up until now, other than what I said at the start, which is that this is so important, it's essential we get it right. But you may or may not know your hospital data has been doing this for the last 20 odd years. And it's been in a form which, if somebody wished to, could be tracked back to you personally, but by and large people don't, because they don't want to, they have no reason to. And that's brought huge benefits. There is a real risk if we get this wrong, that benefit goes too. And I think there's a real possibility here that we could throw the baby out with the bathwater is an understatement. We have benefited immensely from a system that actually has worked for 20 years. It's the trying to expand that out so that you, and Shamila's point is right, this is about being able to link databases. In other words, there's not much point in having a good hospital database if you don't know what happens when that patient leaves hospital. As a consequence of the hospital data, we have much better outcomes of heart attack in this country than we've ever had before and in many other countries, because we've audited it. We've been auditing it through MineApp in minute detail. We know how many patients wait, how long before they get their primary angioplasty, and what drugs they go home on. After that, we have no idea what happens to them, because we can't link those data to the GP data.
Our primary purpose in an evidence session is to hear from our witnesses, but I have 3 colleagues who haven't opened their mouths yet, and I'm not going to get to the end of this session alive if that remains the case. Dr. Nagpal, then Andrew Percy, and then Andrew George.
I just want to say I think there is a difference between GP data and hospital data. GP data is 10 times more rich in terms of patient information. Patients come to their GP to share confidential information. They entrust us with all levels of detail about their personal lives, their social lives, their psychological states, as well as their medical details. It's very different from episodic care in hospitals. I think that we actually lose that trust at our peril. And for all of those benefits, which I think are absolutely well made, we need to get it right for the reasons you've described. And therefore, I think we're all saying, in fact, the same thing, that the emphasis for this next 6 months is actually about getting that sense of confidence and trust right. And in order to do that, there needs to be absolute clarity around the issues around the data, its security, its governance, how you opt out once it's been uploaded, as Shamila mentioned earlier. So that's what we need to be focusing on, because we need to get to that point of trust. But I do want to reiterate that GPs are different. We have got a legal responsibility around the data controller role, which is different from a hospital doctor. If we get it wrong, we are legally liable for actually extracting data that without the consent of patients or without their awareness. So it's a different role.
Okay, Andrew Paul.
I am concerned at the tone of this debate, because I think a lot of people out there in the public have become very fearful now of this and think it's going to be used to market products at them in a way, and I think that's deeply damaging. And I think some of the things that have been said today have added to that and actually really concern me. And what I don't think we have done is focus necessarily on the benefits of it. And when I hear people saying that we shouldn't focus on the benefits, I'm frankly gobsmacked and my jaw is wide open at the idea, because this is really important. And I am very concerned at the way in which this debate has been, well, plenty of other people have had plenty to say today, and I've sat here quietly, thank you. So I'm really am very concerned. So my question is really, I guess, for you two is, has any, who's making those arguments, and has any assessment been made actually that's been put out there publicly as to what this will actually mean in terms of improved patient outcomes? Because I've not heard any of that. All I've heard is a lot of fear, which important data issues, of course, have to be addressed, and I want to see that happen, but we don't seem to be having a balanced debate in terms of what the advantages are. And I know from a couple of constituents who contacted me on this, is that there's a lot of fear, and there isn't really the understanding of what the benefits are.
So can I have a go at that? I mean, I think there are two things. Firstly, medical research charities have put out their own information. We have a dedicated website, patientrecords.org, to try and not to sell the concept of the benefits, to, if I can characterise this side of the house, but to set out enough information so that people come to their own view, their own informed view about whether they want to participate or not. It does talk about benefits, and it does talk about some of the risks. So I think there is some of that conversation out there. My real anxiety is the reason why we have so much fear and so much worry is because the basic communication of the project has been poor, and and NHS England has underestimated, I think, the importance of getting the public's trust and confidence. And in that vacuum has been filled a lot of misinformation, a lot of worry, and a lot of extreme examples. We've talked a bit today about Section 251. It's really important to get that right, but it's only a tiny sliver of the spectrum of things. So, nature abhors a vacuum, and the vacuum has been filled by some of this sort of scaremongering. And if the communication worked better, there would have been more balance in the debate. But I go back to my original point, which is the reason why the communication hasn't worked well is because I think the thinking is not yet fully done. And if the thinking were fully done, it would be better and easier to communicate. So I hope that in this 6 months, I can see loads of shakings of head. I'll just finish my thought. But in this
what it says, when you say scaremongering, we have a duty as elected members of Parliament. There is no information out there, and to accusing us of scaremongering is absolutely ridiculous. People are raising legitimate concerns, and the Secretary of State has dealt with it, but in a private letter. He hasn't chosen to share it. Elected members of Parliament. And I think the problem that's happening now is that NHS England believe that they're beyond the law even, and they don't bother to share things with us. They go off and do whatever they want to do without sharing it with elected members or even with the public. That's concerned.
And that might well be true. I can't
comment raising
on that.
Legitimate concerns.
And I share those legitimate concerns. I can refer back to my initial.
Well, I'll say there has been some scaremongering. I'm quite happy to go on the record. There has been
right. Order. Andrew George.
People are having different opinions.
If I may, thank you for allowing me to speak. I just wanted to really, as this is probably the last question or the last area of questions, try and characterise what I understand. I think it's been well emphasised by those by our witnesses today that medical charities clearly understand the benefits of this and favour clearly the possibility and see the patient to benefit from the kind of data sharing that is proposed under the Care.data policy. I fully understand the nervousness of GPs in wanting, above all, to retain patient trust above all else, but can recognise the benefits that this will bring. And I fully understand the position that the civil liberty organisations have about the risk of the state and companies snooping into people's private lives. The issue which I really want to raise is in relation to Mr. Booth and Mr. Pickles, as to how far are you prepared to push this, and do you see any merits at all in the policy, or are you implacably opposed?
I think we're not sat here today saying that patients shouldn't be able to see the mortality rates of different hospitals. That's an eminently good policy. We're not here saying that research shouldn't happen. I think what we're saying is, firstly, and the pseudonymisation point is an excellent example. If the codes were public, then we wouldn't have this discussion. If NHS England just published the codes, the policy and NHS England have become two very different things. And I think the fact that NHS England, for example, chose to publish the leaflet before its own advisory group had met to consider research use of data was NHS England have been lapping
Okay,
at
let's save a bit of time. I mean, I think, okay, so there's a lot of kind of, nitty-gritty kind of granular issues about procedure and the mechanics of what's happened, and some of the things clearly which should not have been handled in the way that they have, and that's something which we'll no doubt reflect on. But let's imagine a situation where the government have dealt with all of those granular issues, the mechanics and the procedure. We now have a situation which addresses all of those. I mean, do you recognise that there is any merit to this procedure and the patient benefits that might arise from it?
I don't think we have denied that.
Sorry, we have never.
You said it's laudable. You said it's laudable, which is not in itself.
We have never denied the research benefits. What is going on here is the conflation of a whole bunch, as Nick says, of policies. The condition that we require, or would require, to stop is, as you say, all of these nitty-gritty things being finished, being dealt with, but it must be trustworthy. Yeah? What we say is we would like to see all data flows, not just Care.data, in the NHS, that going into it, going across it, going out of it, to be consensual, safe and transparent. And if we don't get to that position, I'm afraid it's not down to what we say. Patients are just not going to trust it.
Let me just be absolutely clear in that case. So you're saying that even if the Care.data policy were resolved, you would still oppose this because of its interrelationship with other data handling issues?
No, that's not what I've said. I've said we would get Care.data right, but that means a fundamental re-engineering of process, transparency, oversight. Some of the bodies are just inappropriate here around the data and how the data is being...
So a complete re-engineering of the entire way in which the NHS handles data?
Well,
that's what you want to go back
NHS England has had 2 6-month bites at the cherries of trying to get this right now. Yeah? There was a delay before from their original September upload of last year. Now we've had another delay. Yeah? This is not just a matter of poor communication. It is a fundamental problem with the system that they're trying to sell to people and not selling very well.
Can we even capture that?
Even to the point where, you've heard the research charities saying that thousands of deaths are avoidable.
Sure.
Okay. I mean, you're prepared to push this to a point where actually we'll have 1,000 more deaths as a result of your opposition to this.
I think the point is the fact it is not a good thing that we're sat here saying for 20 years this has gone on and no one knew about it. That's not a good thing.
Well, but that's going with the past. We're dealing with what's now.
So let's deal with the fact that the public know about this, they understand how it works, so they see the benefits, there are benefits.
Yeah.
But let's not rush ahead and try and
do this. We've got to pause so we can sort these things.
Sorry,
and it will affect everything else.
I need to jump in. I sat down, myself and a colleague sat down with representatives of the AMRC and I spoke at the Wellcome Trust last year. This is not happening now. Yeah, we were around well before this all came to public attention, and we sat down and we said in terms, be very, very careful about hooking yourself up with the Care.data programme, because the way it looks to us, number one, you probably won't get the consent that you need. Number two, you probably won't get the data quality that you need, not for a while anyway, and you could get dragged into a situation where you start to, by hooking yourself up with something that is going to be a bit of a mess, and it was predictable, you are going to undermine the research enterprise.
Right, and Valerie Vaz, and then we need to move on to the second panel.
It's actually quite a technical one, which follows up on what you've been saying. The Data Protection Act, there is a controller of data. Who is the controller of data under this system?
Well, it's changed. It's changed.
The GP is the data controller for the data that is held by the GP practice. So that first extraction that takes place, the GP has to be comfortable that patients are aware of that data leaving the practice. When it then goes to the information centre becomes the data controller for that data.
But that's changed in the last few days.
Okay, But I think actually we're getting to a place where most of us are agreeing that it's of course important for the benefits to be articulated.
I just really want to stick. I really don't want speeches because I've been the last.
In that case, no. But that's the answer to it, and that's a problem for GPs. We need assurance that our patients understand what it is that is being extracted, the benefits, and to make as well as the risks, and to make an informed choice.
So once the data leaves you, it then goes to HCIC, and then they become the controller.
Sorry, can I jump in? So this has changed in the last few days. It was the case that the Information Commissioner had come to an arrangement with NHS England, HSCIC, and that HSCIC was essentially the nominated data controller. But in reality, because NHS England is defining the purpose for which the data is being processed, it is a data controller. Yeah? So you've split out, if you like, the person who's deciding, or the body that is deciding what is done with something versus the body that is doing something with it. So now, my understanding is, and we'll write to the committee about this, my understanding is very recently the Information Commissioner has agreed that basically NHS England and HSCIC are data controllers in common.
Right.
For Care.data.
So does that absolve GPs?
No.
Right.
No, the
we've
first
got
extraction.
3 people who are liable now, have we?
The first extraction is still the GP remains the data controller of that first extraction of data that leaves the GP practice.
And patients who want to complain, who do they complain to? Their GPs or the HCIC? Or if they think that something's happened to their data, or they don't know, they want to stop their data flowing, who do they go to?
If uploads were to occur today, and if half of the population are not aware of the existence of Care.data, and a third have seen the leaflet, and then they en masse complained that their data had been uploaded without their awareness, without their consent, without their understanding, I think that would put us in a very difficult position as GPs, because we would not have fulfilled our responsibility, which is why we're looking forward to the next 6 months enabling our patients to be properly informed, both of the benefits and the risks, so that they can make an informed choice about whether their data should be extracted or not.
And in the meantime, are the BMA taking legal advice about what your position is?
Absolutely, and one of our recommendations, and what we would want, is indemnity for GPs. If GPs do everything that they should, remember we're compelled to upload that data because of the Health and Social Care Act's requirement that we upload. So we're put in this very difficult place, on the one hand having to stick to the law, and on the other hand having to be data controllers, and we would like to ensure that where GPs do what they should do, that they're indemnified against any legal action, which is, I think, absolutely a fair thing to be asking for.
And one last question. In the Telegraph yesterday, I don't know if you read that, Andrew, but in the Telegraph yesterday there was an incident where data has been sold to an insurance company. Are you satisfied that with your reassurances that you've had, that the committee hasn't had, or any member of Parliament has had, that won't happen again?
No, I'm not satisfied at all, because the assurances we have had are about simply the operation of the opt-out. It is not about, as I say, putting in proper oversight, proper transparency, proper processes at the HSCIC. It is my understanding at the moment, this is looking at what has happened historically, that there still appears to be, within the definitions that we've read anyway, wriggle room for if these further research. So let me step back. At the moment, the use of Care.data has been approved only for commissioning purposes. So no research purposes has yet been approved. Right. The process of applying for research uses is basically ongoing. At such point as research purposes become approved for it, that will open the door to commercial companies as well as research, private sector research organisations, all sorts of people. There does not appear to be any way in certainly the legislation that we've seen to prevent one particular class of people, and certainly not with any statutory power. There may be some internally imposed guidelines, but frankly then why wouldn't a pharmaceutical company or insurer sue their way in? If the data is that valuable and other commercial companies are able to get access to it, it seems a bit of a weird one. We haven't seen any language about that
and I think this
that would exclude them.
Is that a view shared on by Sharmila?
I've got two things I want to say in my kind of concluding remarks. I think the first thing is to say I was really clear at the start that there are huge execution issues, and one of those is about who can use the data, including insurance companies and actually government too. It is very, very unclear. But I think the question that needs to be answered is not about the identity of who's using it, but the purpose for which they're using it. Because I would submit I wouldn't like an insurance company to have access to my data, but neither would I like the DWP. So it's really, really clear that we've got to be clear about purpose as well as identity. The second thing I want to say, I want to correct Phil Bede's assertion there that somehow medical research charities and the MRC, who I think with these were hooked up with Care.data. Nothing could be further than the truth. Medical research charities are hooked up with research. So we're hooked up with our patient groups, we're hooked up with the research benefits, and we have been really clear in this committee about the risks and about the harms. And I know you're going to talk later on in your second session about how to rewire some of this. I hope that you can help to rewire it, because it's very, very important that it works better. But it is really important not to lose the benefit that can come from this system if properly executed, if properly wired, and if properly explained and discussed with the public.
I think identity and purpose is important.
People like access can write to patients and say, for example, it happened to me, we'd like to invite you to join a research programme on cartilage problems. If they're not getting this information now, how do they do that? How do they identify it?
There is a. I mean, Caldecott too. We've talked about this. Identify. There is a real problem here in what they call the consent for consent issue. So a researcher needs to find who he can ask if he would like to be involved in the research, but he can't do that without seeing these data. So there is an issue about consent for consent, and one of the ways of tackling that is this pseudonymised thing.
Yeah, but here we go. You tell me it's not happening now. And
I don't tell you it's not happening now. I'm telling you we need to get it right now.
Nobody's got permission to do it right now, and it's happening. So you want to get everybody to join in, and actually, in principle, I'd like it right. But if you can't do it right when you're not supposed to be at it, what are you going to do when you've got any power?
I agree. I read the Telegraph article too, so I agree with you. It's got to be right.
And do you actually think that Atos is a fit and proper company to be extracting care data?
I don't.
It's outrageous.
Fine. I think on that note, we will draw this spirited session to a close. Thank you. And move on to the second panel. Minister, you don't need any introduction to most members of this committee because you were once, not very long ago, a member of it. But could I ask you to introduce your two colleagues, please?
Yes, certainly. We've got Max Jones from the Health and Social Care Information Centre and Tim Kelsey from NHS England.
Thank you very much. Could I begin by referring back to the session we've just had, where we had representatives of those who have expressed serious concerns about the conduct of the Care.data programme, the chairman of the BMA committee, BMA GP committee, and also two representatives of medical research charities. I think the striking thing was that all five witnesses said that they were in favour, in principle, of better handling of data and the use of data for research and indeed improved patient care, which was perhaps the theme that was underrepresented in that panel. But all five were in varying degrees critical of the way the Care.data programme had been handled, and all five argued that it needed to be rewired to a greater or lesser degree, in most cases a greater degree. Do you agree with that analysis?
I think in terms of the way that the programme has been communicated, I'll leave that to Tim Kelsey from NHS England to talk you through that. But I think it's undoubtedly the case that this is a positive programme. It's one that, as you've outlined, Chairman, it has huge benefits in terms of if we can link data effectively. It has huge benefits in better helping us understand how to integrate and join up the health and care system. It helps us to understand the basis of illness and disease processes much more effectively, not just in designing care pathways and improving care pathways in conditions like chronic obstructive pulmonary disease, heart disease, but also in getting a better understanding about the effects of medications and the damage that can be caused by various toxins to the system. I mean, I think there's no doubt that we'd have known much more about the dangers of smoking and the like if we'd had better joined up data in the first place.
Could I interrupt you, actually, because I think we need to get into the heart of this, because exactly the same case was made by the lady from Shamila Nebrajani from the Associated Medical Research Charities. Exactly the same argument was made, but it was her who said that the programme is flawed because there's no definition of who the legitimate users are, there's no definition of what the safeguards are that patients should be able to rely upon, and there's no legal foundation for the right of a patient to withdraw from the programme. So it's the definition of the safeguards that is in danger of derailing exactly the objective that you and I think the majority of people probably would share.
Well, I don't agree with the analysis that has been put across. I think a lot of it has been perhaps down to the more recent issues to do with how perhaps the message has been communicated, and I hope that today we will be able to bring some reassurance about this matter. I mean, the basis for the Information Centre in this is in the Health and Social Care Act, as we are all aware, and there's a statutory basis for it, and the safeguards for the use of information have been strengthened by that Act to make sure that information is used when it is used for the benefit of the health and care system. There are also requirements on the Health and Social Care Information Centre in Section 263 of the Act, 264 and 265, to have rigorous processes in place for ensuring that data is used in the right way and in the right way.
No, why do you sell it to insurers? Don't make statements and have no evidence base to them.
The safeguards that are in place in the Act mean that the data can only be used for the benefit of the health and care system.
So why did you sell it to insurers?
One by one, yeah. Finish I'll come to that point.
Health and care system, in terms of where we actually are with how those safeguards are. They've been put in place by the Act, which means that the Health and Social Care Information Centre is run with much stricter. Let me finish.
Who's getting sacked for selling it to insurers?
Let me finish. The Health and Social Care Information Centre has much stronger safeguards in place than the NHS Information Centre did, which is the predecessor body, because of the 2012 Act. And I've tried to outline to you some of the safeguards in there. I was interrupted in the process, but there are, for example, needs to be a code of practice set forward by the Health and Social Care Information Centre on making sure that information is kept confidentiality. I think it's under section 263 of the Act. There's also needs to be regular updates in place. These are new things that are in place that weren't there before, and there are much stronger safeguards in place under that Act. And making sure that for the first time, information that is used can only be used if it's being used for the benefits of the health and care system, except under very specific statutory exceptions, of which that wouldn't be recognised as one.
You've mentioned section 263 of the Health and Social Care Act quite a bit, and you've talked about the safeguards of the HSCIC. Can you tell us then that, as you will know, under section 263, the HSCIC are required to publish a code of practice? Now, you'd have thought when you're embarking upon something that's sort of quite risky in terms of patient confidentiality, that you would have made sure this code of practice was in place before you embarked on the system. But as you all know, if you've read section 263, it requires that, and there is no code of practice. Can you tell us why there's no code of practice, and when there will be a code of practice? And if you can't give me specific dates, could you possibly write to the committee?
Mr. Jones can talk to you through the process in place. But I mean, if we look at the fact of the matter is here, this is not a revolutionary sudden change in the way the data is being used. In 1989, we had hospital statistics, inpatient data being put forward.
With respect, you're not answering my question,
2003, the use of outpatient data. 2007-8 A&E data, and now we're going to be putting together general practice data into the mix.
One of the things that you were listening for. It's a shame you weren't here for the previous session, because you would have heard some of the concerns, and basically the session was about all the questions that haven't been answered before this scheme has actually rolled out. So it seems to be done the wrong way around. Now, one of the things that a code of practice would have answered is most of the questions that came out of the last session. So I repeat, why have we not got a code of practice?
I'm coming to Mr. Jones will comment on this, but this is a body that's been in place as a new body for less than a year. It's been in place for 10 months. So as that body, they have then taken on, as part of this evolutionary development and the move from being what was previously the NHS Information Centre into the Health and Social Care Information Centre, they've taken on board additional responsibilities, some of which are coming in towards the end of the year. And so in terms of developing the code of practice, that needs to reflect how this new data will be used in the system.
Develop a code of practice and develop your mechanisms before you switch the machine on. So it seems like you've got a half-built machine, but you switch the machine on, and of course the product that comes out is very flawed and is alarming a lot of people.
Should we let Max Jones answer that question?
Of course, sorry.
So can I take you through some of the very helpful steps I think we've taken that can reassure you about the seriousness with which we take the obligation to control access to this data and to protect it. So we've implemented processes for controlling access in line with the ICO's Code of Practice on anonymisation and the Data Protection Act and, as the Minister said, the Health and Social Care Act. And access is very clearly under the Health and Social Care Act dependent upon the purpose for which you wish to use it. And that's a fundamental shift in the way in which information access is controlled. So we need to have reassurance that the purpose for which this information is being used is to support the better implementation of health and social care. We also make sure that only the minimum amount of information is released for the purpose which is approved. And specifically for Care.data, the only purposes which are approved are for commissioning. So that is a very significant further clarification which we have in respect to the Care.data process programme. Now, in addition, there are two categories of information, both de-identified and personal confidential information. For personal confidential information, we would require specific patient consent or a Section 251 exemption, or in the case of a public emergency.
So is it untrue that this information has been sold to an insurance company, to take Rosie's Cooper's point?
It is indeed untrue. The information, if you're referring to the recent press,
going to the press complaints or whatever it is.
There has been a variety. There's been a variety, I think, of misrepresentation of the facts, and if I can help to set some of those out, then I will. As a public sector organisation, the Health and Social Care Information Centre does not seek to make a profit from selling data. It operates on a cost recovery basis only. We did release some data to the Institute and Faculty of Actuaries, which is a not-for-profit organisation. But that information was released by the predecessor organisation prior to the current statutory controls in place. It was not released by the Health and Social Care Information Centre.
A point of clarification. So you're talking about non-profit organisations. Is it just that an industry, like the insurance industry, or pharmaceutical industry, or the life sciences industry, to take examples that are involved, all they have to do is set up a non-profit body of some sort to be the front,
no,
and then you will say, this is a non-profit body, I can let them have this patient data for a very cheap price.
Absolutely, that's not what I'm saying. What I'm saying is that this was approved prior to the Health and Social Care Act being in place and prior to the existing organisation, the Health and Social Care Information Centre being formed. Yeah. Today this would not be approved because it doesn't meet the criteria for the benefit.
Let Charlotte finish. Yeah.
Very key point. What you've told us is very interesting, but you haven't answered my initial question, which is why haven't you published a code of practice within which this would have been published, and a lot of the questions that were raised in the last session wouldn't have needed to arise. Why haven't you, and when will you? Because it is in section 263 of the Health and Social Care Act. Now, of course, if you have published a code of practice, what you're about to tell me about how things have changed would be set out, because it's not clear exactly how things have changed. No rules or regulations are pointed to. Now, if you publish that code of practice, everything that we're talking about here would have been set out. So I'll just ask one more time, and I want a yes and a no, and or a date. Why haven't you published the code of practice, and when will you? And if you're not prepared to answer now, please could you write to the committee and give us a date on which that code of practice will be published, because that will be the first stepping stone in putting to bed a lot of the questions that are causing public lack of confidence. Can I have an answer, possibly, please?
The code of practice is being drawn up. The Health and Social Care Information Centre, under the obligations under the Act, has to consult widely on that proposal, but I will be happy to come back to the committee with a note on when we expect that.
Could you write to us with a timetable for the publication of a draft and then the later adoption?
Indeed.
Consultation partners.
Indeed.
Thank you very much.
Right. Andrew.
Thank you. Just on this, the story that was in the Telegraph, which is the one that has obviously gained some public traction in the last few days. I just want to be clear on this because, I want to see data used and shared if it's for health benefits. I don't want to see it flogged off to insurance companies. So you've said very clearly then that the data that has been reported on and that was released to the actuarial, whatever group they were, would not have been made available under the new regime. So that's very clear. Yep. Okay. So what was the previous regime, and where does the statutory framework for that date back to then? So, and when was it released? When was the data released?
The data was the contract was in 2012, but as this refers to a predecessor organisation, I'm not sure that I can directly answer the question about what the situations were.
But
at that point
I want to know what was the previous regime. And what piece of legislation underpinned the previous the release of data under the old system?
Health and Social Care Act 2006, I believe.
So the 2006 Health and Social Care Act allowed the release of this data. The new rules wouldn't allow the release of this data. That's very clear, isn't it? Because obviously this has now been conflated with the new regime. So there are the concerns that have been raised around the current.
I think that's an important point because clearly we are dealing with different regimes that set up, and I think that the changes that were put in place under the Health and Social Care Act strengthen the safeguards.
Could we understand precisely what the changes are compared with the 2005-6 regime and how it changes with the 2012 Act?
Firstly, there's an express express requirement that information has to be used for the purposes of health and social care, so effectively for the NHS, for the benefit of the NHS and the health and care system, effectively, and that's very clear from the Act. But there are also additional safeguards in place, and we discussed to some extent the idea of the guidance that needs to be put in place. But sections 263, 264 and 265 specifically talk about making sure that there is a rigorous and ongoing assessment process, and that is required of the Health and Social Care Information Centre to make sure it has safeguards in place about confidential data and protecting confidential data.
And if I might also offer, the board of the Health and Social Care Information Centre at its meeting, I think in January, also required that we publish on a quarterly basis details of all those people to whom we make information available, on what legal basis and for what purpose. That is anticipated in advance of the HSCIC's board meeting in April.
Could you possibly send us a copy of the old rules and the new rules to clarify? And also, can I just clarify, will the insurance company have deleted the data that they have in line with the new rules? Can I just get clarification that you'll send us the old rules and the new rules?
We will indeed.
Can I just ask, you say this was issued in 2012. Why did you do it? Have you given actuaries and insurance companies this information before? Is this setting out a mindset? Because it doesn't matter what the rules were, you actually did it. Why did you do it?
For the avoidance of doubt, we, the Health and Social Care Information Centre, did not.
Who did it then?
The previous information centre, which was in existence prior to
Who
April
are they?
2013.
Who are these anonymous people? Are you all recycled into this new organisation?
I was not part of the old
well, who
information
headed up
centre.
the old?
Its chief executive was Tim Strawn.
Who?
Tim Strawn.
Can we have him visit us, please?
Well, maybe.
No. It's quite important. These people are making decisions.
Can we be clear that the position now, the position, Minister, is that the rules have changed. This is information that was made available within the law at the time to an insurance company. The law has now changed. It would not be made available in future. Is that an accurate summary of the position?
That is an accurate summary of what we've discussed, yes. And we will write to you, as discussed, giving an outline of what the previous arrangements were under, well, I believe, the 2006 Act, as Andy Percy has asked for, and then we will make sure that we then indicate how the 2012 Act has put in place enhanced safeguards in terms of confidentiality.
I'm just slightly confused because, as I understand it, the ISIS insurance report from the actuarial company has the new 2013 HSCIC logo on it. Can you comment on why that might be? If it was under the old rules?
They asked for permission to use a logo to indicate that there was copyright for the information.
That's very confusing. And will the...
Sorry, so who owns the copyright to this information?
I think we will need to write to you and clarify that.
So basically, you're not did it. We wouldn't do it today, but you can have our stamp to make sure everybody knows
Could
it's
we,
kosher.
I think, if you accept your offer of a written evidence to cover what happened in this insurance company information. So, Dr. Wollaston wants to pursue that a step further, and then we need to move on.
The Stapling Actuarial Society report in front of me, and very clearly it says the Health and Social Care Information Centre within it, branded. Now, are you going to retrieve that information if it's currently illegal for it to have been released? And I have to say, I'm very disappointed. What we're hearing from the panel is that this is somehow a communications problem, and in fact, really, we are. I think we would share the objectives that there are huge benefits to be obtained by sharing data, but I'm afraid the way it's been presented is fundamentally undermining public trust in this. And I think to come before the committee and present this as some kind of communications issue when there are very serious underlying problems here that need to be addressed, I think is very disappointing. I haven't heard an apology yet for the way this has been
presented. I think Tim Kelsey from NHS England, they have been handling the information side. It's important to hand over there, but actually this is something that was debated very robustly and very fully as part of the Health and Social Care Act, and there was a lot of debate around that Act. We had 2 standing committees in the House on that Act. I remember being a part of those committees. It's very thoroughly debated by the House. All of these processes had huge scrutiny, and perhaps more scrutiny than any other bill has had, probably in a generation. So there has been very large scrutiny of this, and the benefits were discussed and talked through. And I think the point is that this is something that we believe and has to be a good thing for the health and care system, because it's about improving research. It's about
stop you there, because there's a kind of paternalism about this, and there hasn't fundamentally addressed some of the very legitimate concerns.
But it's not.
About the data.
We can come. Actually, there are concerns, and we need to talk about those. But fundamentally, this is a good thing, and there is an opt-out system that allows people. It's not a compulsory system. It's an opt-out system that allows people to say, actually, I don't want to do this. The Secretary of State made sure that that was the case, and that was a very effective way of saying if people don't want to be part of this, they can opt out.
Mr. Kelsey has...
So just to explain, NHS England is the body which commissioned this programme from the Information Centre under some very tight on a tight legal basis, which we've had discussed. Can I just slightly move this on a bit, because I think the thing that I want to communicate, if I'm permitted, is the fact that this is not a communications campaign. This is one of the most important things the NHS is currently doing, and this is not some PR exercise.
It's the way it's being presented.
No, so I took the decision that we were going to extend the period before collections begin for 6 months, precisely to deal with some really big issues that have been raised to my attention by our partners in the BMA, RCGP, by a whole range of stakeholders with whom I have spent an enormous amount of time listening. And the 3 things that I want to communicate to this committee to some of you, in fact, but oh no, I've been not to part. Well,
you've talked to everybody apart from members of Parliament.
Okay.
Yeah.
The 3 things that we over the next 6 months need to get right, because this is such an important programme. I hope I don't have to explain why, but I will at some point.
We actually want to deal with protecting the public and making it work from arrogant people who are making decisions in their name.
Yeah, no, and I share that view entirely. So the 3 things I heard.
Mr. Kelsey, please, can we?
The 3 things I heard were absolutely that people are concerned about appropriate assurance of the purpose to which their data is being put. That we do actually have some very strict legal safeguards, but we need to talk about how we can strengthen those assurances. That's really important. That's something that everybody has said, and I absolutely share that interest. So we are going to spend time talking with the government and with as many stakeholders as we can about how we can ensure that appropriate assurance is in place that guarantee the purpose of the Act, which is that this data cannot be used for any other purpose than the benefits of health and care. That's the first thing. That's the first thing. Just the second thing to address is some very real concerns, which I've spent a lot of time with colleagues in the British Medical Association and the RCGP, about the degree to which GPs under very heavy workloads are suddenly finding that they're needing to communicate about this new programme to patients. They're feeling they haven't had enough time nor enough support in some cases. They feel they haven't had opt-out forms. There are some basic things they feel they need more of, and certainly we're going to be talking to them about how we can support them much more closely to make sure that they are equipped with the right information to have a proper conversation with their patients. And the third thing, actually, I think, although you've heard it today, is to some extent, and perhaps we're all too close to the benefits in the health service, is just to explain to the general public, to citizens at large, why this matters so much. I'm not sure we have made the case for the benefits of this, and obviously people do have the right to opt out of the programme. We want to persuade them this is way too important for them to exercise that right, and that's something else that we need to do. So this is not a PR exercise, nor is it a stunt. In my view, it's one of the most important public debates we're having, and it is about the future of the health service. So I welcome this committee's support for the principles of it, and I'm very interested in listening to your views as to how we can ensure that we take the public with us.
Well, David Trudini.
And I've been in this place a long time, that I think the Minister's badly advised and yourselves not to attend the earlier session. And the reason this committee...
We were in attendance.
You were at the back of the room?
No, not personally, but our teams are all here in attendance.
Yes, but not yours. Yes, but I have to.
Well, I would say watch not even on the television.
Sorry, I'm not sharing this. Order. But order through you, sir. The point I'm trying to make is that we have just, the reason the committee, if I think through you, Chair, is, to put it mildly, excited about these issues, is what we've just heard over the last 2 hours from witnesses who are saying that there are major concerns over issues such as pseudonymous data, what it means, what is data, when is data one sort of data, when is it another sort of data, and you didn't hear this intricate debate, which I think is a great pity. And to sum up really the answer to the question that I'm about to pose, which is here, which I asked the last session, what do you hope to achieve by postponing the start date for data collection by 6 months? The 5 members of the who presented to us just now, 5 representatives, were really saying that we've got to go back to the drawing board. We've got real concerns about the way that data, the legal definitions of this data. The doctor's representative was saying that we're in a panic as well. We didn't use the word. We are very concerned as doctors that we have a legal 2 duties of care. We have duties to pass information up and then it changes its status. We have duties of care to patients who can sue us if we release the data. And it did sound like a very serious muddle. And so the impression we got from them was that they needed 6 months as a breather. And I hear from Mr. Halsey that this is really, and I think this is the concern I'm hearing around the table, although I'm not chairing the committee, is that it's not a public relations exercise. What we've got here are fundamental issues, and these have to be addressed. And I'd ask you to comment on this. What are you hoping to achieve by postponing the start date for data collection by 6 months? What exactly are the key points?
Just one comment on that, David. I think that's, and I then get Tim to talk about the engagement exercise that NHS England are doing. We, as the Department of Health and the government, listen to stakeholders. We've been listening to those. We've had those discussions. We listen to things, and and my belief is that once we have had further engagement with stakeholders, we will be able to reassure those stakeholders that actually there are very rigorous safeguards in place under the 2012 Act. I'm sure that we will be able to do that and to make sure we are in a better place. And that is something I believe will be in the case. So I think it is down to actually to his own extent about how well it's been communicated as an exercise. And Tim from NHS England has said that. And I think that is, and I'm sure when we have the discussions with stakeholders, we have further reassurances, that will be something we can convey. And obviously we listen to concerns and we take those on board, and that's important. But I'm sure those reassurances, everyone will feel in a better place. Tim.
So just to say, we worked very closely when this project was first initiated with the BMA and the RCGP and other key stakeholders on designing the information that was first distributed to GPs back in the autumn and subsequently to the general public. We worked with them on the protocols of the helplines, the patient and GP helplines. We published data in a whole myriad of different places with, in fact, in the end, more than 350,000 patient bodies. So we didn't do nothing, but it wasn't enough. And towards the end of January, I was picking up from, as I say, mainly from GP organisations, that real concerns about the degree to which GPs just hadn't had enough time or enough resource to have a proper conversation with patients, plus this big issue about the degree to which people were satisfied with assurances in what I think has been a very confused media reporting environment, where things like the illegality of insurance purposes, as it actually is, was just lost in a melee of slightly informed reporting. So that's what we therefore intend to achieve now, is to work with our stakeholders, all of whom have committed to doing that, BMA, RCGP, none of whom have lost sight of the purpose of this, Health Watch. We will be working with them incredibly close to develop a whole programme that will meet the 3 things I just said. So the first of those is absolutely to provide more support to the public and the primary care community on raising awareness of the purpose of the programme and the rights that people have to opt out of it. The second, and to be very clear about what the opt-out means. Another thing that came back to me, was that people just weren't clear about it. What did it mean? It's actually pretty straightforward. It means when you opt out, the first opt-out, no clinical data flows from your practice, but that message just got lost. So we need to re-embark on making that really clear to people, and also making it much easier for them to actually make that opt-out. So unfortunately, in some cases, GPs got a bit confused. They were saying to people they had to go physically into the practice and so on and so forth. We need to be a lot clearer about that and use available digital technologies to make it just easier for people to opt out. So those are things that are real criticisms, and I fully accept those. The second thing, so those I think were the key issues. And essentially, for the next couple of weeks or so, we will be working with stakeholders to develop the programme, and then we will be able to make some very concrete proposals to this committee and more broadly about what we propose to do to meet these criticisms.
Right. I have one, through you, Chair, one further.
Sure.
I'm sure colleagues want to come in on what you've just said,
yeah.
But I also would like to add, from what I've heard and what we've heard at previous hearings in listening to other inquiries, is that there isn't a proper understanding of this priceless asset of a primary and secondary national database, international perhaps if you look at devolved administration, which other countries such as the United States of America don't have because they get all sorts of protections. And it's critically important that this is out there, as the professor from the Heart Foundation has just said to us earlier on, because then you can work out why I think it's elm bark, which is aspirin, actually does kill some patients, but you need a massive database to work out which patients get killed by taking aspirin in a certain situation. And so you have got to get this message out, too, about just how important it is that you're dealing with what you've got there is fundamentally important to the nation's health, and I don't hear that message.
No, well, so just very quickly on that point, I personally am at risk of colon cancer. It's something that sadly runs in my family, and I recently went for a procedure in my local hospital in Taunton, and I was besieged by the staff of that hospital asking me why Care.data wasn't happening quicker. They don't have that. We've been very good. We've been very good at understanding lots of useful things about hospital care. We've been able to improve quality in most surgical procedures because we have used the hospital episode statistics database. Our ignorance of what happens to people outside hospitals is one of the key reasons why, at the moment, sadly, England has one of the lowest cancer survival rates in Europe. Care.data is not just about research. Care.data is actually also about genuinely saving lives in the NHS. I hope we're all agreed on that. And what I've got to do, my job, is to make sure that in 6 months' time we have the public with us and we have GPs in a place where they feel they have been able to exercise the responsibilities they've properly got to inform the public.
So in the spirit of being helpful, there's two suggestions. I have two suggestions for how we might use the 6 months. And firstly, I don't know if you've seen George Freeman's bill on insisting that this is all done in a new statutory framework of patients' rights, which would also enshrine this idea that patients are responsible and own their own data. Is that something you've considered?
Charlie, you know for years my personal position on this has been absolutely that we need to be very clear. This is patients, their data, it's our data, it's people's data. And I've been personally very supportive of George's bill.
Brilliant. And the second thing is we've actually got a system that has worked well for some time in terms of pseudonymised at source. And two largest companies are providing GPs with this, with 80% of coverage. TPP, I think, is one of the companies, and it's used in sort of big research technology, it's used in big research projects like Q Research. Now, this is already working. Why can't we just do this? Yes, it might mean that the data can't be, because it's scrambled before it goes to the information centre. Yes, it might be more difficult to pass on to third bodies like insurance companies or police. But this is already working. It has the public would have more faith in this. Why can't we just use this?
So the technical solution we've implemented at the moment does not implement pseudonymisation at source. I am not yet convinced that pseudonymisation at source will indeed offer a technically viable solution at a national scale. Wow. However, we recognise that there was a need for us to continuously look to see whether or not we can find opportunities to do better. So in November, we started an exercise to listen to some of those key stakeholders on what opportunities there are to further strengthen pseudonymisation, not only at source, but also on publication. And we have been engaging with exactly those suppliers, but also representatives from other suppliers and other stakeholders, and we'll be looking to see whether or not that offers us some opportunities in the future. At the moment, I am not yet convinced that it offers a sensible way forwards, and I think it's not only about making sure that we take best use of technology, but also that we protect the quality of the data which will result at the end and the quality of the data linkage, making sure that in doing pseudonymization at source we don't prevent the ability to link data across data sets. In particular, though GP data may well not be the highest example of this, I think in particular where you have other care settings that may not have quite as high a presence of NHS number, then pseudonymization at source may well present some very real qualities to our ability to bring together this shared record and understanding of patient care. So right. I think an open mind, but not yet convinced.
And the final recommendation, this is come to me by someone who wants to use the research, is as I understand it, the data will not be historical, will be taken, I think, from October 2013. Now, someone who does research said to me that that completely devalues the asset that data might have in terms of research, because you can't see the longitudinal effects of a drug. My final suggestion, is this going to be the case? And if we are going to put, jeopardise public confidence in where the data is going to go for a greater good, which most people agree is the data good, could we please have data that's really useful to the research community and is historical and longitudinal, not taken from October 2013?
So just from the Commissioner's perspective, so we work very closely with the BMA and the SGB on the original specification of Care.data, which is not actually the entire record and also is not the historic data. One of the things I want to do in this conversation is to take the research community to the BMA and the RCGP and other GP colleagues and to understand better what the additional labour burden might be in opening up more historic data. That's a proper, real conversation. We're at the beginning of a journey here. This is a new thing for everyone, but that's exactly the kind of conversation we should be having.
Barbara.
I just wanted to say some things about context, because over the last few days I've seen NHS England described as incompetent and arrogant over this database, and I think that that's a serious thing, because there are some seriously good uses here. And I think it is a pity that you say that you listened by proxy somehow to the previous panel, but we heard from Dr. Chan Nagpal that there was a real difference that he can see between GP data, which is personal, confidential, might include information that never would reach a hospital record about domestic violence, mental health issues, all kinds of things that people wouldn't want to just be out there and found out about them. And they see that as really different from the sort of episodic data that hospital data is. And I would think that most of us here would want you all on the panel to admit that information, whether or not you want to challenge it, about like the release of hospital data, patient data to those insurance actuaries, is actually undermined confidence. I did a BBC interview this morning, and the person was on the street in Greater Manchester, the BBC person, asking people if they'd heard of the Care.data database. Not a single person asked had heard of it, not a single one of all the people they stopped. And when they had it explained to them what the database was, they said things like, well, it's just another way the government is going to spy on me. And there was a very particular concern about somebody believing that it would be used either to sell things, and so he would be bothered at home with phone calls, or that information about possible mental health issues in the past would be disclosed to employers. Those are the real fears. And I think unless you can take those things seriously, I think even 6 months won't be enough. And one other thing I wanted to say is that there's a great deal of talk in the NHS these days about stakeholders. I think these patients, every single patient whose data you want to do something with, is the real stakeholder. So that's just a thing about context. This project is about the personal, confidential medical data of patients, which, as Dr. Nagpal has said, is a thing based on trust, and that you can, if you get this wrong, and you are getting it wrong, you can undermine the trust between a patient and the GP, which will itself be to the detriment of future medical care. I mean, let's not run away from that. These research arguments about benefits, very, very important, but if you undermine whether somebody will disclose a mental health problem, will disclose HIV status, will disclose alcohol or those other issues, then you really have got an issue. So I want to talk about how you propose to go back to the public and how you propose to win back the trust you have lost. You have lost it. The organisations, you can say it was a previous organisation. That doesn't matter to the public at all. And undoubtedly, the HSCIC has some people that used to be in the previous information centre. So let's forget about saying it wasn't me. So there's been suggestions in the previous panel of ways of safeguarding that important single database. Ways that you could prevent the re-identification of data. If you don't think, Mr. Jones, that what's been suggested, pseudonymisation at source, is a way to do it. How will you do it? You know, you can think, and it sounded a bit of, you know, just me. You know, I'm surprised that it is just you that takes this decision about how to safeguard data. The second thing that was raised, and I think this is important, is the system of fines. The fines that people get for misusing personal data, patient data, are derisory. I read an example of somebody misusing data in a GP practice and being fined £990. That is a joke. To pharmaceutical companies, small fines are just not worthy. And I think it is being talked about that we have a loophole whereby it is not a criminal offence to obtain and misuse personal data, and that is something for the government to reflect on, I think. And the thing that seemed to me, and I used to work in IT, to be very compelling is that particularly at the start you could run with a single copy of the database and run queries against that data for the organisations whose medical purposes you approve. Not be in the situation of loading personal data out to people, because as we've discussed in our previous panel, there is this problem. If somebody withdraws consent later, how are you going to get it back, if you like, if a data set has gone out to a research organisation? So those have been put to us as ways of moving forward and safeguarding the data. Could you tell us when you're going to go out with some sort of new offer to the public? Are you going to include any of those safeguards? And more than anything, we've had quite a debate already about what happened with the insurance actuary data. There might be other examples of dodgy applications. Will you make available, certainly will you make available to Parliament, Minister, all the minutes, attendees, all the applications that we use that perhaps don't fall within the new rules? Can we know about everything dodgy that went on in the past, so that at least people can know how, you know, and get that out of the way? Because I think what is going to kill this is if we keep having insurance actuary stories all the way down the road. And there does seem to me to be floating about stories that GPs have actually been offloading data and, you know, in exchange for IT systems and other support. There's been various examples of data floating about and being used out there. So let's, you know, make a fresh start, get all of this information in and you know, come clean with it.
Can I respond on a couple of those points very specifically? The GP extraction service that we have in place to support extracting the data from those GP systems for Care.data took great care to make sure that we only extract the coded information in those records, not the free text notes which patients may well have shared during consultation with their GPs. In addition, we also created a number of explicit conditions which were excluded from those extractions, and those include HIV, AIDS, sexually transmitted infections, termination of pregnancy, IVF treatment, complaints, convictions, imprisonments, and abuse by others. So we have already...
But not mental health issues?
Not mental health issues specifically.
Of which we know there is a considerable stigma.
Quite frankly, that's absolutely daft, because we've got a disparity in this country between mental and physical health, and if we don't have the data collected properly on mental health, we're not going to be able to have the evidence in order to improve mental health conditions. So I think it's absolutely important getting the right data in place is the right thing.
Can we come on to the other points? Because clearly, in terms of what I said about people being stopped on the street, that is a worry to somebody. They fear if that data gets out, it would be disclosed and it would affect their future from a whole variety of points of view. So there is a real fear in the public. If they come up with that unprompted in a street interview, then it's a real fear.
So just to make the point that we are going to be launching a very sizable programme of activity to do the three things I mentioned, which specifically involve, first of all, articulating the purpose of this programme very clearly, articulating what the safeguards are very clearly, and inviting people to make a choice about whether they want to opt out of that programme or not, based on what we're saying about the safeguards. That is that's why we're having the 6-month extension.
And will you reconsider any of the safeguards I touched on that were put to us in our earlier panel?
Well, I think I can't speak for the government, but as far as NHS England is concerned, we are taking very, very seriously the fact that even with the existing provision of safeguards, which are the tightest they've ever been, we're still not satisfying people that actually somehow the state isn't going to do dastardly things with their data, and we need to look very, very carefully at how we can...
They don't think it's the state. We're in a situation
or,
where...
the state might sell their data to some other party. Yeah, we need to look really carefully at how we can provide appropriate reassurance that is not going to happen. So yes, the answer is, and all the stakeholders you have before you, I know very, very well, and indeed are all engaged in the conversation we're having about what happens next.
But Mr. Jones has already told us that the suggested way of preventing re-identification of data, pseudonymisation of source, is something that he considers not worthwhile. So you're already, at the start of the 6 months, seemingly rejecting things which other people have suggested you should look at.
I don't want to speak for Mr. Jones.
If I can clarify then. So we take pseudonymisation as a critical key tool that we use inside the Health and Social Care Information Centre. And under the Information Commissioner's Office Code of Practice on Anonymisation, we implement and adhere to the limited access safeguards that it sets out. And I'll read those to you. Purpose limitation, making sure that the information is only available for specific purposes. Training recipient staff, personnel checks on those staff, controls over linkage to other data, limitations to specific projects, restrictions on disclosure of data, prohibition of re-identification, measures for the destruction of the data, technical security arrangements including encryption, limited copying of the data, and contractual penalties for breach of rules. And to go back to the comment that you made about the £900 fine, if someone was to do, let's say, a jigsaw attack against this pseudonymised data, they would fall foul of the Data Protection Act. And my understanding is that as of 2010, fines up to £500,000 are possible.
That would mean nothing to a drug company. That would mean nothing.
In addition,
or an insurance.
They would breach the terms of the contract which they would sign in receiving that data, and then the HSCIC would need to...
Right, okay. Order.
It was suggested... I mean, I don't expect you to answer these points now. What I'm saying is that in the earlier panel, a number of safeguards, additional safeguards were suggested, and I think I would just like to hear that you would think about them.
And I think what I was trying to say about pseudonymisation is that absolutely we are looking at that with those experts to see whether or not they feel at a national scale there's something we could do.
If you think now that a £500,000 fine would stop anybody who had a data interest and a lot to gain from matching up their own data with this data, then I think you need to think again. It was suggested that there's a loophole in our legislation that we should look at and make it a criminal offence to do that. We're talking about the personal data of a lot of people.
Graham.
I think that's an important point, Chairman, and I hope that whether it's Mr. Jones or Mr. Kelsey would respond to the committee. If they can't do it now, then perhaps you could consider it and identify the appropriate statutes that members have raised. But I just want to ask some technical questions, perhaps to Mr. Jones or to Mr. Kelsey, regarding first of all the cost of Care.data. What is the actual cost of the project? And I'd also like to ask a few questions about how the system will operate in practice. Is it true, a number of members have suggested that Atos will be providing the technology, and I wonder if you could confirm or deny that that's the case, and whether other IT suppliers would actually be involved in the mechanics, as it were, either nationally or regionally. And if that was the case, are there any technical issues that have been reported to date in respect of problems over compatibility if there are different regional centres using different operating systems, or is that something that you've already addressed? And I've got I'll just get this down. In terms of the concerns that have been raised, and we all recognise the value of this one. But the Minister said it was an evolution. I think it's a revolution in terms of the nature of the data. It's a whole, it's not just a kind of raw data. This is a kind of a holistic approach covering all aspects, primary care, hospital care and lifestyles. But my question is this. What is the critical point on opt-out? If a certain percentage of the population haven't got trust in the system, when does the data set then become of limited value in terms of research and development? Something that everybody wants to avoid. I just wonder if you've made any assessment of that.
So I'll try and respond to each of those, but I'll let Tim probably consider your last one there. So you are correct that Atos were awarded a contract to be the supplier that extracts the data from the GP systems. That contract was awarded under the old information centre regime, and we are working well with Atos. But the data, once extracted from those GP systems, is brought into the safe haven of the Health and Social Care Information Centre. It is processed by our staff in our data facilities. And
is that on a national basis, or are there regional
that's on
offices?
A national basis.
Right.
Although HSCIC does have regional offices, that information is processed and held on a national basis.
Okay. What about costs? Do you have any information about what's cost?
I mean, I can tell you what we've spent so far, if that would be helpful. So the Health and Social Care Information Centre has spent £1.17 million so far on the Care.data programme. I'll let Tim respond to your latter point.
Yeah, so it's really important on the opt-out. So to an important extent, any data at all is useful. Clearly, we want as many people as possible to agree to share their data in the programme. The larger the amount of data, the more useful it will be, but there is no point at which the data is of no use. So there is no percentage at which this becomes useful or not. It is useful at every point of its sharing.
Mr. Jones, just that information you gave me on costings, I wonder if you might just double check that, because I've seen a written answer that suggests the estimated cost is 33 million over 3 years. That might be incorrect, but I'd be grateful if you could check. And if the information isn't correct, perhaps you could advise the committee.
For the avoidance of doubt, the figure I gave you was our spend to date within the Health and Social Care Information Centre.
Right.
I don't recognise that figure that you were referring to.
And the cost of the contract with Atos?
I don't have that figure with me, but I can come back to you with a note.
That piece of information, please.
I just wanted to follow up something that you said, Mr. Kelsey. You said it's never not going to be useful, the information, but suppose 90% of people opt out.
Well, to some extent, it depends how important you think this is for the future of the NHS. Do you think the NHS can fly blind in delivery of out-of-hospital services? So if 90% of the population decide that they would only give the NHS that proportion of their data, we won't have a health service very much longer. We won't be able to run services effectively.
That is scaremongering.
well, anyway. I mean, it's just a view I have. I've had it for a long time.
Information has been flowing for a while, hasn't it?
Not in out-of-hospital services. In hospitals, of course, it has.
Yes.
And look at the degree to which we have managed to improve outcomes there.
Well, let's go to Dr. Foster, because actually Professor Blake is actually looking at the way Dr. Foster's figures have come out.
Well, I'm not sure.
No, you're not associated with Dr. Foster anymore, are you? Are you?
No, I'm not.
No. But there is some concern about the information that's coming out of it.
90% would not be a good position for us to be in.
Okay.
Yeah.
Okay.
Dr. Willison.
Thank you. What we heard from the last panel is that the concern was not just about the identity of those accessing this data, but the purpose.
Yeah.
And one of the specific examples that was given was whether or not government would access the data, like the DWP, and what the purpose would be. And as you will know, there are many sensitivities around Atos in any case. So I think it's clear. I think it is reasonable to see how the public could be concerned about that. And what I'm wondering is, are you going to have a very clear, concrete offer to the public at the end of this 6-month delay as to how these requests will be handled?
Yeah.
How transparent that will be, and that therefore they can see if their data is going to be accessed by the DWP, because I suspect a lot of people would choose to opt out at that point. And I accept that might not be for purposes that would be harmful, but it's what the public believe, and I suspect they wouldn't trust that. And I think they need to be able to see that very clearly. And also, I think it would be helpful if they could see this information backdated, and the point's already been made by another member of the committee. Will you set out who up to now has made requests for data, how it's been adjudicated on, and the minutes of those meetings, so that we can have a clear transparency about who is making these requests and how it's being decided upon? Will you give us a clear guarantee that will be in place?
So I can't. So the Information Centre handles the as it were, the process for application. So I'm sure that Max will give you some assurance about it. But can I just say that for certain, for Care.data, that programme, there will be full transparency of all uses. All users will be audited from the moment. So just in terms of timescales, we've delayed the initial collections till the autumn. The actual linked data files won't be shared for some time after that. We can give you the project plans as those develop. The timetable for the initial collections will be October the 1st from that point onwards. But from the moment at which data is shared, I give this assurance that there will be complete transparency of all organisations and of all uses to which that data is put, and that there will be appropriate audit of those organisations to ensure that they can be, they can be properly regarded as safe to handle this kind of information.
And are you planning currently to share this information with the DWP?
At the moment, we're completely prohibited from doing that, unless the DWP can make a case that somehow it's helping the health and social
reading
care.
directly from the Health and Social Care Act, this has to be in the interests of the health service in England or of the recipients or providers of adult social care in England.
Right, but you could see a situation in which the DWP might argue that actually it's be quite helpful for them to contribute to the process. Say, for example, fitness to work. Would you say now that you would not be giving other government departments that data?
I think the Act is, it might be very clear about the purposes of which data can be used. So I think the purposes you're describing, I don't fall within what is written in section 254 2B of the Act.
What is the definition?
But how will that adjudication be made, and will that be very clear to people so that they can opt out at that point? Yeah. So we'll have a clear chance to offer to the public. Thank you.
Ultimately by a court.
Yes.
Sorry. I actually did too. What is the definition? Who is going to decide what is in the interests of people? You read out a definition. Who decides that?
Well, I do. I did, but I'm actually not a lawyer, and we will obviously during this period want to provide further evidence to assure the public that they can work through case studies and understand all the steps that we'll take
now.
To show people.
You're doing it now.
So is it you that decides?
Sorry, the board of the Health and Social Care Information Centre does have the responsibility at the moment to make sure that it is adherent to the terms of the Health and Social Care Act.
Right, Andrew first.
Thank you, with your permission, Chairman. Just on this issue of government departments then, because I share the concerns actually of DWP accessing some of these records, but would the old system have allowed government departments to access that information or not? Because obviously we understand that this flogging of information to the insurers happened under the old regime couldn't happen now. Would the old regime have allowed government departments to access that information?
I'm not aware of any cases where other government departments have had access, but I'll be happy to come back with a note that clarifies if you're aware.
That would be helpful, because I think it's very clear we want to know what the new regime allows compared to, which I think was Barbara's request earlier, as opposed to what the old regime would have allowed, because the two have been conflated in a very dangerous way.
Yeah.
Well, they're I accept they're accessing different data, but we're still accessing. Well, we're still dealing with people's personal data. I understand we didn't have GPs, but we had plenty of other information on which was incredibly personal. So it would be important to know what the difference is.
Yeah, I think I think we're very happy to clarify that in the note. I think it's very useful. It has been a lot of conflation of what things were before the 2012 Act and how things are and operate now, and I think that has led to some of the misunderstanding and that has been about. And I hope that we brought some reassurance today, and we will do so further in writing. But it is important just to clarify that point about saying actually this cannot be clearer in the legislation, that it must be in the interests of the health service in England or the recipients or providers of adult social care in England. That is very clear. That is not about DWP. It's about the health service and social care.
I was a lawyer for the government previously, and I had to make a definition of what is in the public interest.
It's not the public interest. It's in the interest
of
the health service.
In the interest of.
In the interest of the health service.
Really wide definition.
That is a very narrow definition. At the health service, the NHS in England, and the social care system in England, which is very clear.
To pursue the point.
Not particularly that, but just others, and I do want to pick up something. I just want to put this to you. If someone has actually already opted out, what happens under the new regime? Are we going to have to opt out again?
Opted out of what?
I've already opted out of Care.data UK.
Yeah, you won't have to do so again.
I won't have to do it again, even though you're coming up with a new system with new safeguards and you're discussing...
We're not going to change the mechanics of opting out, nor, for example, the definition of the data set that's being collected from GP practices. So if you've opted out, that remains, you're opted out.
Okay, and could I just ask you, Mr Jones, were you told to commission the dissent codes in such a way as to flow any data whatsoever from GP records who have opted out?
So for the type 1 opt-out, so if this is someone who does not want their patient...
Don't do type 1, type 2, you need to explain.
Which is what I'm about to do. If you choose to opt out of information at a patient level going to the HSCIC, then the HSCIC will not extract anything associated with your patient record through that GP extraction service I've just described. We will extract a count of the number of people in each practice who have objected. That will not contain any details about individuals. That will be to help us in monitoring the way in which opt-outs are proceeding.
But once you've opted out, that's it. Your data can't be extracted at all, all the way up the chain.
Correct. Yes.
Okay.
Correct.
Right. And on what basis will you, NHS England, or you, HSCIC, decide to allow patient data to be shared outside the European Union? Say, for example, in America,